this one. Student Dr. Motzko is a standout student at KCU. She's approached me in several ways vis-a-vis research, so we're extremely excited about this one. She has a strong interest in OB-GYN at present, so she's chosen to talk about COVID-19 in the context of obstetrics and gynecology. So with that, I'll hand it over to Shelley, and you can do the introduction.
Thank you, Dr. Staudinger. It is my pleasure to introduce Micaela Motzko. She came to KCU with a bachelor's in health sciences from University of Central Arkansas in Conway, Arkansas. While there, she founded a successful student-led service dog raising club and wrote her honors college senior thesis titled Raise a Dog, Change a Life, an Interdisciplinary Study of Raising a Future Assistance Dog for Canine Companions for Independence. Since joining KCU, Micaela has helped as an anatomy tutor and an anatomy teaching assistant, both of which qualified her for the anatomy fellowship she is currently completing on the Joplin campus. Micaela is also an extensive volunteer, leader in many KCUMB student activities, and thoroughly engaged in giving back to her community. She has volunteered with Global Health Outreach in the Dominican Republic, helping with health screens, establishing clinics, and dispensing medications, as well as in Livingstone, Zambia, where she volunteered in a rural clinic. She is staying engaged during the pandemic by helping KCU administer COVID-19 testing, volunteering for the COVID-19 Journal Club, and helping on Dr. Staudinger's internally funded research study, an interdisciplinary approach to improving clinical outcomes in patients with opioid disorder. I will turn it over to you, Micaela. Remind everybody to please mute their mics and raise their hands if they have any questions. Thanks.
Thank you both for the very nice introductions. So for those of you who don't know me, my name is Micaela Motzko, and like Ms. Boyer and Dr. Staudinger said, I'm interested in obstetrics and gynecology right now. So that's kind of the area that I was interested in pursuing for this presentation. So I'll share my screen, and let me see if I can go. Let's see. Is that showing for everybody?
Yes.
Okay, great. So the route that I was taking, I was kind of interested in seeing how exactly pregnant patients might be affected differently by COVID-19. And this kind of led me down a rabbit hole of using chest CTs to diagnose COVID-19, and then how that might show a more severe disease course in pregnant patients. And the CDC has come out and said that pregnant patients are probably at a higher risk of getting severely sick. And based on just my background knowledge on this topic, I would assume that it's probably due to the fact that pregnancy itself is kind of an immunocompromised state already, just because the mother's immunity is being suppressed in a way to not harm the fetus. And so I was curious to see how a pregnant patient might be affected more severely, perhaps. And that's what I'm going to share with you today. So I found two papers, and the first one is just talking about the utility of chest CT versus PCR testing. And then the second one's diving more into the pregnant patient. So let me get started on the first one. This is the title, and it was published in the Journal of Radiology. The authors of this study, their goal was to show the utility of chest CT and kind of comparing that to the rate of diagnosis using PCR testing, which is important in areas where PCR testing might not be as available or maybe not as reliable. And so to begin, I'm going to give you a little bit of a background on what the PCR testing is. So reverse transcription polymerase chain reaction is kind of the gold standard of testing for coronavirus at this time. It's pretty sensitive and specific, and the results can be obtained in as little as 3 hours. So that's kind of why people like it. So basically it works by the sample being collected from the patient's upper or lower airways, and then that is extracted as RNA. And if the virus is present, the virus RNA will be in there as well. And so then the RNA goes under reverse transcription to become a double-stranded DNA. And then the double-stranded DNA is what can get amplified. And if the virus is present, that's how it'll be detected. But these authors have pointed out that there are some issues with PCR testing. So their main issue was that sometimes the sample collection is faulty if the swab isn't put in the back of the throat thoroughly enough, or the back of the nasopharynx enough, it might not get a valid collection. The transportation, especially in epidemic areas like where this study was completed, sometimes the transportation will delay the PCR testing, and then that'll cause the samples to expire. And then also sometimes kits just aren't reliable. And then in areas where they might run out of PCR tests, that's an issue as well. So the authors used the PCR positive rate for their sample as the baseline positive rate for this study. And then that is what they compared the positive rate for CT scans to. And so now that I've talked to you kind of about the basics of PCR, let me tell you about the basics of a chest CT. So computed tomography is standardly used to diagnose pneumonia, and it shows the lung fields pretty clearly. So those of you who may not be familiar with a CT scan, let me get my pointer so I can point out some things. Can you see the red dot moving on my screen?
Yes.
Hopefully. Okay. So this is a completely normal, healthy patient chest CT. So this is as if this slice was taken directly through the midline of someone's body. And then what you're seeing is the patient's laying on their back. So this is their spine here. And then you're looking at it as if you're looking from the perspective of the patient's feet, and then you're looking towards their head. So in the middle here, this is kind of the mediastinum, which includes all the great vessels of the heart, the aorta, pulmonary trunk, all of that. And then as it branches out, all of these vessel markings that you see out here are the smaller airways and the vessels as they branch into the lungs. And so this black lung field is a normal finding. You would want that to be as black as possible for a normal lung. But what we've noticed is that COVID-19 pneumonia has a very specific type of pattern on chest CT. So it's not found in other types of pneumonia, which is why the chest CT is an interesting way of diagnosing the COVID-19 pneumonia. So what they call it is granulous opacity, which is what you see here with these, they're almost like little wispy cotton ball type areas in the peripheral lung fields. And the other thing with the COVID-19 pneumonia is that it's typically bilateral, so in both lungs, and it's usually always around the peripheral border of the lung fields. And then the other finding that they say is pretty common in this pneumonia is the what they call crazy paving pattern. And so I have a zoomed in picture here of it. These are kind of, it's caused by the interstitial changes of the inflammation in the lungs. And it just causes these interesting, crazy looking lines within the lung fields. And so because the COVID-19 pneumonia has these very specific findings, the authors suggest that CT scans may be a more reliable way to diagnose COVID-19 in patients who have all the clinical findings, but they maybe got a negative PCR test. So now I'll tell you about the methods that they used for this study. So the data was collected from this hospital in China, which they mentioned was an epidemic area, and it was a retrospective analysis. They used 1,049 patients that were suspected of COVID-19, and all of those patients underwent CT and PCR testing. They ended up excluding 35 patients, so the total sample was 1,014 patients, and the data was collected from January 6th to February 6th of this year. And so the PCR test was either positive or negative, and the positive was the rate I mentioned earlier that they're kind of using as the baseline. That was the 59%. But then they had to have a way to diagnose the CT scans as positive or negative as well, which is what I'm going to show you now. So for CT interpretation, they had 2 radiologists, and they were blinded to what the PCR results were. But they were given the history and clinical symptoms because that goes into whether or not a patient is more likely to have the virus. And then they had to agree in consensus on whether or not they believed the images were positive or negative. And if they found out that the patient had a negative PCR test but a positive CT, they would do a repeat CT just for clarity. And they would classify them as either highly likely, probable, or uncertain. And that's based on whether or not they had clinical symptoms and positive repeat or clinical normal repeat and so on. And so the radiologists, when they were interpreting these CT scans also noted some really common findings that they found between all the patients, which I'll show you now. Out of all the patients with positive chest CT findings, 46% had the ground glass opacities, which is what I mentioned earlier. And then 50% had consolidations and 90% had bilateral findings. And so after all of that, let me show you what their findings were, the actual numbers that they came out with. So I mentioned again, this PCR positive rate is 59%, but the CT scan positive rate was 88%. And then if you look on this diagram, they found that 580 patients had the positive PCR plus the positive CT, but 308 patients, had negative PCR, but a positive CT scan. And so that's 30% of their total patient base, which I thought was pretty significant. And they also calculated the sensitivity, specificity, negative and positive predictive values for these results. And these are biostatistical measurements that are usually used to determine how effective a test is. So in this study, the test that they're measuring is the CT scan. How well does it perform? So I'm going to tell you what their values were for this study, but as I go through them, I'm going to explain what these definitions are for those sensitivity, specificity, negative and positive predictive value, because they're kind of more of a jargony term in biostatistics. And I want to make sure that you all understand the significance of those numbers. So sensitivity and specificity tell us basically how reliable the results are. So for sensitivity, it means the percent of true positive. So how well does the CT actually detect people who actually have COVID-19? And their sensitivity was 97% for this study, which is a pretty good outcome. And then the specificity is the number of, or percent of true negatives. And so this is telling us how well can the CT rule out people who don't have COVID-19. And you want this value to be a little bit lower as well. And that number was a 25%. So both of those are desirable outcomes when it comes to these statistical definitions. And then they also, like I mentioned, calculated the positive and negative predictive value. And these values are basically telling us the probability that a test outcome is correct. So how likely is it that the positive or negative result was actually right? And that's based on kind of the prevalence of the virus in the total population as well. So for the positive predictive value, it's telling us that the probability that a patient who had a positive CT truly has the virus. And that was a 65%. And then the negative predictive value is the probability that a patient with a negative CT truly does not have the virus. And that was an 83%. And then the accuracy they calculated as well at a 68%. So now I'm going to show you some of the patients that they outlined in their study that was like chest CT examples of negative and positive findings. So first of all, this is a 29-year-old male, and he had a 6-day fever. He had a positive PCR test on February 5th, but you can see in this CT scan, this one's almost normal. Here you can see he's kind of starting to develop ground glass opacity right here. And then it becomes a little bit more developed here. And then now it's bilateral in this lung field and this lung field. You can see it up here as well. And then it's kind of resolving over in this pane, but he had a positive PCR test happening here. This is another patient who had a positive PCR test. Is a 46-year-old female, and she had a 4-day fever. And you can see here she had the ground glass opacities occurring here. And then they're kind of resolving as you go along. And then her positive PCR test was on February 4th. So it would be like right in between here. So it's interesting to note that she had these CT findings even before the PCR test was done. So that's kind of an interesting thing about CT, is that maybe if the disease was early enough, the CT scans might show it, but the PCR test might not. And then now I'm going to show you some patients who had negative PCR tests, because now you should be familiar with what we're looking for. So this patient has the typical findings that we would look for in a COVID-19 pneumonia. The ground glass opacity is occurring, and then they kind of resolve as you go along, but they're definitely present. And this patient had negative PCR testing on 2 different occasions, on February 3rd and February 11th. And so this was a 62-year-old male. He had 2 weeks of fever and 1 day of dyspnea. And so that's pretty interesting that he had negative results on 2 occasions. And then this is the last one I'll show you. This is a 63-year-old female with an 11-day fever, and she had a negative PCR test, and she also had 2 assays done. And hers is also kind of interesting because hers doesn't really seem to resolve as we go along. Over about a 16-day period, her results are just continuing to get worse, and she still had negative PCR results. So I found these to be really clear examples of how PCR might not be as reliable as we would like to think, and how the chest CT can give some conflicting information a lot of times for diagnosing the virus. And so for the total number of their conflicting findings, they had 308 patients with negative PCR plus positive CT findings. And then on there, I mentioned earlier that if this happened, they would do a repeat CT, and then they would classify them in one of these categories. And so out of the patients who had conflicting results, 48% of them were still considered highly likely, and then 33% were still considered probable. And then there were 21 patients who had positive PCR but negative CT findings as well, which the authors wanted to point out as an interesting finding. And there was also conflicting data between if patients had multiple PCR assays done. So there were a couple of patients, like I mentioned on the patient examples, that they would have one PCR test done and then another one, and then their results sometimes change from negative to positive or vice versa. So that is laid out here, where they had 258 patients who had multiple assays done. Out of those, 15 patients switched from negative to positive, and then 57 patients switched from positive to negative. But what I thought was interesting was that even if their results changed, out of this group, 14 out of 15 still had the positive CT findings, and then 56 out of 57 still had the positive CT findings as well. So even though the PCR test is switching, the CT findings were still there. So in the discussion section, the authors do point out that there's still quite a bit of utility in PCR, just in determining hospitalization and isolation. But again, just due to the limitations, it might not be as feasible if the kits are running out, or if transportation, or if hospitals are overloaded with needing to run the tests. And so the CT can be more reliable, practical, and it's also able to show the clinical course of the virus. So even before maybe a PCR test is completed. And then they pointed out that 97% of patients with a positive PCR assay also had positive findings on chest CT scans. So this tells me how reliable the CT findings are, that if 97% of them had the positive PCR test, they also had the chest CT findings. And lastly, one important finding that I thought was worth highlighting was that 81% of the patients who had the negative PCR assay, then they had to, then they were classified as having COVID. 81% of them were classified as highly likely or probable. So out of the patients who had conflicting results and their PCR was negative, 81% of those patients were probable to actually have COVID-19. So that's quite a big population that could be missed by these PCR tests. So my takeaway from this paper is that if patients do have a negative PCR test, but they have high clinical suspicion of having COVID-19, hospitals can and probably should be using exposure history, clinical symptoms, and the CT findings to identify COVID-19 with higher sensitivity. And before I ask or open for questions, I just want to point out a few of the limitations that they had. The use of PCR testing as the baseline might have skewed some of their sensitivity and specificity for the CT scans, just because the PCR positive rate was pretty low. So it might have overpredicted the CT scan sensitivity. And then they also noted, the authors noted that because of the epidemic area that this study was completed in, there was some limited clinical and laboratory data. So that's the end of this paper. Does anyone have any questions?
Any questions for our speaker? Shelley Boyer, go ahead.
Micaela, thank you for the talk. That was great. I was curious, and I may have missed it in the beginning, but did all of the patients / participants kind of in this study, did they have symptoms prior to being the PCR testing? Were they showing
Yes.
symptoms of COVID before they did that?
Yes, the sample of patients that they collected, all of those patients were suspected of having COVID.
Okay, I thought so, but I wasn't sure if I missed it or
Mm-hmm.
not. Sorry.
Mm-hmm.
Thank you. That was
Yeah,
a
so
great
they
talk.
weren't. Yeah, they were pulled based on having this clinical suspicion.
Okay, great.
Thank you.
Thank you.
Dr. Schneider, go ahead.
I'm Micaela, great presentation. I have a question for you regarding the cost of the procedures. How much
Okay.
estimated that CT will cost for diagnostic purposes as you described?
That is a really good question. And I actually don't know how much CT scans would cost, especially at different hospitals in different parts of the world. But I can definitely look that up and email you later and send you that information, because that's one thing that the authors didn't point out at all in this paper, was the fact that PCR testing is probably a lot more cost effective.
Michaela, I had the bills. I had a couple of CTs when I had a broken leg. It cost kind of few hundreds, right? So therefore,
Okay.
it's probably indispensable for clinical management when you have a patient and to monitor the dynamics of disease. That's definitely paper which says, please do it because you can see a lot by repeated CT scan. But for the screening, wide screening population, which is not in, right? So I don't know exactly whether authors proposing it for the diagnostic purposes, outpatients, but I would doubt it. But clearly for me, if I'm working with these patients, that's nice to see how its dynamics goes and explain why therapeutic approaches do not work, right? So you're showing a couple of cases where there was no positive dynamics for long, right? And again, thank you for presentation.
Thank you for your comment and your question, because that was something that I didn't really consider much of. I will say, I think the authors were more so trying to point out the fact that if there are patients that, so only the patients that had a negative screening, but then they were highly suspicious, like clinically suspicious, like the patient who had a 2-week fever still had a negative PCR. I think that is kind of the point of that it would be in those patients to confirm, not so much as a widespread screening.
Michaela, that is a called proof of concept study. It's showing that yes, you can apply and look here. It's a solid work. All right, thank you.
Thank you.
Michaela, I had a quick comment. I think it's interesting to note, particularly in the early days of this pandemic, before everybody had PCR testing in place in a solid way, that this was an incredibly important method of diagnosing COVID. Even in this country, when it first started hitting, even in Joplin, I heard of a lot of clinicians saying, yeah, we just get them CT scanned, and if we see this ground glass opacity, and they're symptomatic, that's good enough for us. And then that was actually how they even screened patients who were going to get a PCR test in the very early days in Joplin.
Oh, really? Because they were such shorthand, I guess.
It's short supply. Yeah.
Yeah.
Yep.
Okay. That is interesting. Okay. So I'm going to move on to the second paper that I had. So this one is kind of getting more into the nitty-gritty of pregnant patients, which is what I enjoyed more. So the authors of this study were referencing other articles like the one that I just talked about, acknowledging that chest CT scans can be critical in diagnosing COVID-19 cases. But the angle of their paper more so is to discuss the chest CT findings in pregnant women and children compared to non-pregnant adults. So since I've already covered a lot of the background of chest CT and PCR testing, I'm just going to jump right into the methods of this paper. So this had a smaller sample size. It was 60 patients. They ended up excluding one, so only 59 total. This included 41 pregnant women, 14 non-pregnant adults, and 4 children. And then the clinical and chest CT data were obtained from these 2 centers. And then all the patients were already diagnosed with COVID-19. So they were either diagnosed using a PCR test or they were diagnosed using chest CT and clinical findings. But all of these patients were already established at having COVID-19. So because this study was focused more so on the severity in pregnant patients and children, the authors were focused on kind of the involvement of the lungs, more so whether or not COVID-19 was present. It was more so how much is it affecting their lungs. So they paid close attention to the findings in much more detail. Instead of just looking at ground glass opacity, they were looking at all kinds of findings, which I'll list here. These were the features that they were looking for. So the number and distribution were important because I mentioned the peripheral findings and bilateral findings that it's typical in COVID-19 pneumonia. And then they also mentioned the ground glass opacity, and then this reticulation is the same thing as the crazy paving pattern that I mentioned before. And so again, these CTs were interpreted by 2 radiologists, and they agreed on whether or not these lesions were present. And using these findings, the authors developed kind of a scoring system to quantify the severity of the chest CT scans in order to compare the pregnant and the non-pregnant patients. So this was their scoring system. So each lobe of the lung was given its own individual score. So for one patient, they would have 5 scores that were then totaled together. So you can see if it was 26 to 50% of the lobe was involved, it would be considered mild and get a score of 2. And then all 5 scores would be added together for one patient, and that would equal the total severity score. So I'm going to show you a few of the patient cases and the example CT findings that the authors included in their paper. And the authors didn't include what these patients' specifically total severity scores were, which I was hoping they would, but they didn't. But I do have data at the end, like towards the end, that shows you what the overall total severity scores. But for these individual patients, this is just their CT findings. So this is a 29-year-old non-pregnant female, and she was diagnosed using a PCR test. She had a high fever and cough for 2 days, and you can see she has that ground glass opacity occurring here, and then it resolves gradually as we go along. And I also don't have the dates for how far apart these were. And then this is 3 separate patients. So this first patient is a 28-year-old pregnant female at 34 weeks gestation. This is a 30-year-old female at 33 weeks gestation. And then this is a 30-year-old female at 31 weeks gestation. And so you can see their findings as well with the ground glass opacities happening, and this patient has them bilaterally as well. So these are interesting to compare, I thought, just between the non-pregnant and the pregnant patients, because I'm not a radiologist, but these do look more severe to me. Then I'm going to flip back and show you the non-pregnant patient, and then flip back here. They do look, to my eye, they look more severe and involved. And so this will be more telling in the data that they actually collected from the total severity scores and lung involvement. So this is the chest CT findings overall. So the way this chart is organized, this first column is going to be non-pregnant adults. Middle column is pregnant adults who were diagnosed using the PCR tests. And then this last column is pregnant patients who were diagnosed using clinical data and chest CT. So for all the groups across the board, it was more common to find findings in bilateral and peripheral lungs. But then in pregnant patients, they noted that they were more common to have pure ground glass opacity with consolidation, pure consolidation, and pleural effusion. And the authors also note that these are significantly more severe in the pregnant patients because the p-values are listed here, and those are considered in the significant range. So, and you can look at the numbers too, just comparing like this is pregnant, and then this is non-pregnant. So it's kind of interesting to look across the board that the pregnant patients had a little bit more of a severe finding than the non-pregnant patients. And then when they totaled the total severity scores for the patients, these were their findings. For the non-pregnant adults, it was 4.3. And then for the laboratory confirmed pregnant females, 4.4. And clinically diagnosed pregnant females, 4.8. And so again, these scores are directly related to the degree of lung involvement for each patient. So a higher score means more lung involvement, more lung damage. So this tells me that, in fact, the pregnant patients do have a higher risk of developing a more severe complication resulting from COVID-19 pneumonia. In addition to collecting the CT scans, the authors of this study also collected some laboratory data, which is what I'm going to show you next. So again, this layout is non-pregnant adults, pregnant with PCR confirmed, and then pregnant with clinically confirmed. So for all groups, fever and cough were the most common findings, including postpartum fever in the pregnant patients. But the pregnant patients specifically had an elevated leukocytosis and elevated neutrophil ratio, which the authors thought was really interesting finding. And based on my background knowledge on pregnancy, I'm assuming this is because of the changes that occur in a pregnant mother's body and immune system during pregnancy. And I also thought that maybe these elevated cells could be the reason for the extra lung involvement in the pregnant patients. So it could be like chicken before the egg thing. Did these cause the greater lung involvement, or is this a result of the greater lung involvement? And then lastly, I'll show you some of the data collected from the 4 children that were involved in this study, just for completeness sake. Their most common symptoms, again, were fever and cough. And then there was one child that had a co-infection with RSV. But besides this one child, all the other patients in the study were negative for all other co-infections. So in the discussion on this paper, the authors pointed out that the leukocytosis and elevated neutrophil ratio were surprising, that it was unusually higher in pregnant patients. And they also noted that the consolidation lesions were more prevalent in the pregnant patients. And the fact that the pregnant women had a higher total severity score does show that that pregnant patients are affected more severely by this pneumonia. And then it's also interesting that the clinically diagnosed pregnant patients had a higher total severity score than the lab diagnosed. And this could be because when they're diagnosed clinically, it might have taken longer to catch that they had COVID-19. And so maybe the disease had a longer course of action and a longer chance to cause more lung involvement before intervention. And then they also noted that the CTs in the children were kind of non-specific, just the ground glass opacity or consolidation, and they weren't as peripheral findings as there were in adults. The authors also point out that, just like in the last study, that CT is useful in tracking disease progression, which is, something that we talked about, but that's different than PCR being either positive or negative. The CT scans can actually show how the disease is progressing and whether or not the lungs are clearing up. And so lastly, I just wanted to cover some of the limitations. Obviously, the small sample size was only 60 people, so maybe the results aren't as reliable. And then the selection bias, just because the data was collected from patients who were at these hospitals that were specifically for women and children. And despite the limited sample size, I would say, I feel the authors presented pretty supporting valid evidence that pregnant women are actually more affected at a more severe rate by COVID-19 than non-pregnant adults. So does anyone have any questions?
Any questions for our speaker? Dr. Wolf.
Yeah, I'll go ahead and ask one. I was curious. So I don't know anything about this now from how once people are diagnosed with COVID, what the clinical directives are to them with regards to exercise. But I remember when the guy on CNN that got sick, his brother is governor of New York.
Cuomo.
And Cuomo, yeah. And he was talking about how he was advised to make sure that he exercised, that his lungs were hurting and everything hurt, but he was told to fight through it and exercise. And so I ended up wondering whether or not that the severity could be increased by virtue of less physical activity.
Huh. That's really interesting because pregnant patients would be under less physical activity. Yeah, that's a really good question. I do not know anything about whether or not physical activity affects disease progression.
Micaela, I had a quick comment or question. I remember leading up to this in our rehearsal practice seminar sessions with you, you mentioned pregnancy in and of itself puts females in a state of immune suppression.
Mm-hmm.
I wonder if you could comment or give us some of your thoughts on that.
Yeah, actually I was hoping maybe Dr. Bowden or Dr. Schneider could add in on this, but based on what I understand is that the mother's immunity does have some kind of a shift to it in pregnancy, just so that the mother's immunity doesn't affect the fetus. And so it's curious that the results, the leukocytosis and elevated neutrophil ratio are just kind of like inflammation markers. And so I wonder if there's something going on with the mother's immunity.
I see Dr. Schneider has his hands up. Alex, go ahead.
Okay.
All right. Let me turn. Micaela, generally it's considered that pregnant women are not immunocompromised. Immunosuppression happens locally at the placenta interface. But if you look at the woman and we talk about general, let's say, flu virus infection, etc., they don't have increased risk to have more than general population. That is what so. But COVID has it shown, but it's a relatively small group of pregnant women. But again, happens at the interface and not spread as a generalized immunocompromised state. It is local immunosuppression.
Okay, thank you for that.
So this was early days of COVID. At least your first paper was fairly early days of COVID. Has it, now that we are in August, is it still generally true that COVID is a bigger challenge for pregnant females? Or that their disease is more severe, tends to be?
Yeah, I was going directly off of a website from the CDC that was talking about the fact that pregnant patients are affected more severely. So even if they're, like you said, Dr. Schneider, their immunity might not be affected systemically, there's still something that makes the pregnant patient more susceptible to a more severe course.
Shelley, I see your hand is up.
Yeah, Micaela, again, thank you for this other paper. I was curious if in your research you found whether or not maybe hospitals have shifted away from the RT-PCR, if they're still using it with every patient, or kind of update us a little bit on maybe where the testing is now, the antibody versus PCR, if you found anything on that.
I actually didn't do any research on the antibody testing. And as far as I understand, that one might be a little bit more reliable because it tells you whether or not it's present in your system right then. But I know that hospitals are still using PCR just for like screening purposes, like we were talking about earlier after the first paper, that it might be easier just to do a big screening with PCR testing. And that can determine whether or not someone should be hospitalized or isolated or in quarantine and so on and so forth. So I don't think that it's something that'll go away. I just think that the CT scans might be used in the cases where it's negative despite high clinical suspicion.
Yeah, I was just wondering if you'd found anything else on the PCR, just because it does seem like a lot of people are shifting towards the antibody testing because it is, maybe a little bit more accurate, although depending on what test we talk about and where it's come from, that's all still up for debate. So thanks. I was just wondering, and that pretty much answers my question. I think we can't get rid of any of the testing mechanisms at this point because we don't have one that's foolproof, right? So
exactly. Thank you for your question.
More is better. Student Dr. Bates, go ahead.
Hello, thank you for your presentation. It was very interesting. I was just wondering if you had any thoughts about the potential of giving the future vaccine to pregnant women.
Oh gosh, that's a good question. I guess I would be a little bit more hesitant to give the vaccine to pregnant women just because we don't know how it might affect a fetus at this point. I don't know. That's a really good question.
That would be a grand experiment and not one I would jump into personally.
Yeah.
Yeah, I think that vaccine mode would make a big difference too on whether or not you would want to be testing it in a pregnant woman.
Yeah.
Like the Moderna vaccine versus the Russian vaccine.
Right, the different, I think the different vaccines that are developed, I think we're going to start to see once they do come out on the market, maybe which ones would be better for a certain population or, immunocompromised or age group. So I think we're going to have to wait a little bit before we get more data on that.
Yeah, that's a really good question though.
Yeah, thank you, Dr. Bates, for that question. Dr. Schneier, your hand is up.
All right. Split it and take a smaller dose.
I think he's on. I think he's on the phone. Here, I'll mute him. Dr. Wolf, I see your hand is up. Go ahead.
Yeah, I was just sitting here thinking I was going to ask you another question based on the idea that people sit there or are in the prone position sometimes now in the hospital. And, the photos that you were showing, I mean, the consolidated or the ground glass opacities and stuff were in the back sides of their lungs. And so it seemed like they were happening where the blood would conceivably be going in somebody who was laying on their back. And then I don't believe I've taught you about my complement stuff yet, or I guess you did have a little bit of complement. Eculizumab is a drug you probably recognize by now, but there was one of the talks here the other day was talking about how complement might be involved in all of this as well. And so I was sitting here and trying to quickly figure out whether or not there was a role in the complement cascade with things like that. But I was thinking about, if the blood and air are going in the same place, that is potentially giving you a greater opportunity for those opacities to occur, and whether or not laying on your belly so that your blood would fall down to the other part of your lungs, how things like that might all fit together. So that's just me sitting here and thinking. I enjoyed your presentation, but was wondering if it meant anything.
Thank you. I actually don't know about whether or not that would cause an increase in consolidation depending on how the patient's laying. That's a really good question though.
And if you're really pregnant, laying on your belly for a long time might be kind of difficult, right?
Yeah.
They might have special tables for that.
Uh-huh.
Don't they have donuts? Don't they have donuts or something that they to accommodate that?
That's true.
Okay, Dr. Schneier, are you back from your phone call now?
Yes, I got a call probably during this time. I just would like to comment about why actually Dr. Wolf mentioned that exercises, moderate exercises are recommended when sick. Right, so probably it relates to perfusion organs. right? So the beta small exercise allow reperfusion, of course, bringing not only oxygen and nutrition, but also bringing components of immune system for that reason. So talking about exercises now, moving to a pregnant woman at the last trimester. At that time, of course, the redistribution of blood is substantial because the baby is weak, and that's maybe contributes. That's a purely speculation that they have higher or higher grade pneumonia as compared to just non-pregnant woman. That's what my just comment. It's combining. Personally, if I get started feeling sick, I go to the swimming pool and I do 2 miles, and it's a clear view from anywhere. After that, you come, and so because there is a lot of bleach in the water, all right? So it's everywhere in your nose, everywhere. So that exercise is also helping you. It's just from personal.
So how about jumping into the hot tub and then into the ice bath, going back and forth?
In Finland, they practice it all the time. So generally, yes, that will be nice here too.
We'll have to get some cold weather.
Yeah, that's really interesting.
Okay, any more questions for our speaker? If not, I would recommend that we reveal ourselves unmasked and thank our speaker profusely. Thank you so much.
Thank you.